Hello, everybody, and thanks for joining us. I'm Scott Tomko from Healthcare Purchasing News. Today, we're here to talk about successfully applying data-driven real-time solutions to ensure optimal healthcare efficiency. Our experts include Mr. Ashok Muthan, founder and CEO of SupplyCopia, a company dedicated to delivering elite real-time intelligent solutions in supply chain management. In addition, we will also be speaking to 4 members from SupplyCopia's end clients, McLeod Health. This will include Dr. Patrick Denton, Dr. Michael Rose, Carmen Winfield, and Boyd B.J. McCluskey. As founder and CEO, Mr. Muthan leads SupplyCopia in making healthcare systems utilize efficient technologies and software-based solutions to improve quality of care and to reduce cost. Ashok has teamed with McLeod to deliver a transformative technology platform that significantly improved the quality and outcome of the organization's total joint replacement program. And with that introduction, I will turn the floor over to Mr. Muthan.
Hi, my name is Ashok Muthan. I'm the CEO and the founder of SupplyCopia. The challenges in our health systems today can clearly be put into 3 distinct buckets. The first bucket is all about the disparate sources of the data that organizations tend to have. That disparate sources of the data come from multiple systems, multiple formats, multiple standards. They all kind of create a cacophony of data. And as a result of this, it's very difficult to construct a story of your organization because of this challenge. The second bucket that we see is putting together a cross-functional team that has the same objective and how about measuring that objective. So if you really will look at various stakeholders there are the supply chain folks, there is value analysis team, there is OR, there is surgical leaders, executive sponsors, the CFO, the CEO. Everybody needs to kind of come together and in a cohesive manner to have a common objective. So that's the second bucket. The third bucket is all about setting the specific goals, and then how do we go about achieving those goals? Each one of the stakeholders that I mentioned in bucket number 2 come to the table with different objectives, different goals with different aims. We should be able to create a very cohesive goal that everybody agrees upon, not only setting that goal and how that goal is measured. So I see those 3 as the 3 biggest challenges that the health systems face today. Thank you everyone for joining the sessions today. During this whole process, I shall be calling upon my esteemed colleagues at McLeod Health to walk you through the transformation journey.
Total joint surgery, one of the most phenomenal care lines available in terms of outcomes for patients. So 1 year later, people that will describe the surgery as having been life-altering for them, having substantially improved their quality of life, have substantially reduced their pain, have substantially improved their functionality. So this incredibly effective care that has become enormously expensive to deliver, and then substantially constrained by Medicare and a growing number of the private payers by putting the whole episode into the bundles or shifting them to an outpatient payment methodology. And so what's happened in that squeeze is a line that is actually producing tremendous value to the patients, particularly as a result of the bundle. It meant hospitals, health systems, physicians needing to become very adept at, 1, getting the costs managed, getting the outcomes tightly refined to create the best fundamentals. So what we were confronting was an incredibly valuable service in terms of care, value to the patient of the care. We were doing it quite well clinically with very low variability, but we were really in a squeeze with cost. And we were really in a conundrum of, could we afford to diminish our investment in the implant technology as one of the ways to underpin the financials and not erode the care. And so that really became the challenge, the problem to be solved. Valuable care to deliver, a cost reimbursement formula that became very suppressing to the line. Could we alter those financials without putting the outcomes of the patient at risk?
The single biggest asset that every organization has is their data. Their entire story can be told through the power of that data. So as everybody knows, that data continues to be a big challenge. So making that data analyzable is the first step towards any transformation exercise. It's like laying a foundation for whatever you are building up on the top. So it's necessary that organizations take various sources of the data that are buried in ERP system, EMR, EHR, their charge masters, their inventory management, the reimbursement. It's very necessary to bring all that data together, clean that data, classify the data, standardize the data, so that that data actually becomes analyzable. Once the data is analyzable, then the story will begin to emerge by itself.
We pulled data from our ERP, so that's our item master, our PO data, all the way down to the detail of item descriptions and unspec categories and things like that. We pulled the consumption data from our inventory point of view system, so we know exactly what was used on what patients at what time and what room and by which doctor. And then we also enhanced that with our quality and outcomes data and also our financial data, so we understood the full picture of how all that played into our revenue and our total contribution and operating margins.
A bill of material concept originally came from manufacturing. When you are looking to, let's say, manufacture an aircraft, an aircraft is a very complex machine that requires literally thousands of parts supplied by thousands of suppliers. And in the simplest of words, a bill of material is nothing but a list of the products that are actually used in the manufacturing, in our case, that are used in a particular procedure. This bill of material is basically consists of what are the products that are going to be utilized by a physician, what's the make of that particular product, what's the average utilization, what's the brand name. That basically constitutes a bill of material. Why that is important is without that sort of a strong foundation, without a bill of material, it is very difficult to lay the foundation for any kind of a transformation journey. A bill of material is used as a reference point to be able to standardize the products and the procedures in our case.
We've actually had some discussion about the bill of material, which, in our eyes it's our preference cards. And that's one of the things that we've actually been discussing is, how can we take the data that we have today, knowing what our preference cards say versus what is actually used and done in the room, and how can we create a more accurate preference card or an accurate bill of material to say, this is what our data says you should use versus what you did use. And I think that helps us with pulling in or being able to see where our gaps are.
All the physicians went through like their surgery pack. Some of us had all these extra stuff, and do we use it all the time? No, but it's in there in case we need it. We try to standardize that the total knee pack contains all this, and that will cover 85 to 90% of cases.
Establishing a cost structure for any organization is the base, without which you can't really measure anything. And we all know that anything that cannot be measured cannot be improved upon. And that's why it's necessary to establish that cost structure. Now, this cost structure for any organization is basically buried again in multiple systems. The product information and the pricing information is going to come from item master. Then there are the indirect costs that are buried in a financial system. It is necessary to be able to bring all of the cost for a particular procedure by a physician in a single line item, so that establishing that cost structure and understanding, how that cost structure obviously varies, it's very important. And it is necessary to bring the direct material costs, the indirect costs associated with a particular procedure, and all the other costs, so that we have a base comparison, an apples to apples comparison.
SupplyCopia was able to help us visualize that. And some really phenomenal insights came from that. It was unbelievable in the variation in materials going into a case. Thousands of combinations among 9 or 10 surgeons. And they were able to then define among the about 10,000 combinations of stuff that people used in their informatics. They were able to help us identify which combinations could most effectively be put together to get the lowest possible cost. And then as a safety net, what they then helped us do was to craft the system by which we could provide surveillance to the outcomes of the patient.
Integrating the reimbursement data with the cost and the utilization is very important, because you are going to deal with the different demographics of your patients. You are going to deal with different payer types. So your payer type is going to be a mix of the insurance companies, Medicare, Medicaid, self-insured, and those patients belonging to self-payer kind of organizations. So it's necessary to understand on a dollar of billing that we do today to any one of the payer organizations, how much of that, what percentage of that dollar is actually being reimbursed. It's very important to understand that. And at the same time, be able to compare that for the different demographics of the patients that we have, and also to the various other factors that play into that whole reimbursement management. That leads to an important question of, if this is how we are being reimbursement for every dollar that we bill, how do we go about doing a commercial construct of our contracts? So when you integrate your data, that is utilization, the cost and the reimbursement, that basically triangulates your 3 important points. And then there are various insights that are going to come out of the triangulation of this data.
This is where we get to see everything in one view with respect to cost, quality, and outcomes. So a physician can log in and they have the ability to see, how much did this case cost me? How much was the charge to the insurance? How much revenue did we actually receive? What was the direct, indirect cost of that? And how does that translate into a contribution margin and ultimately the operating margin for those procedures?
Integrating the patient demographics is another leg of this, this whole transformation journey, if you will, because there is a deep understanding that the choice of a particular implant or the choice of a particular product that a physician uses is depending on the patient demographics. So for example, a physician might decide to use one implant for somebody who is in their 30s, who is very athletic, who's got a huge life expectancy in front of them, versus somebody who is already 80 years old, who have a different set of requirements, in their lifestyle. So patient demographics is very important to understand, whether that is connected with their body mass index, what's their predisposition, whether there are allergies, and all of this is very important to understand. And then to be able to say whether there is a correlation between the patient demographics and the choice of the implant or the products that a particular physician uses, and then go further and be able to say, does the outcome actually vary by the patient demographics or the usage of a particular product? So this gives a tremendous amount of insight in that transformation journey.
For us, the challenge, the specific challenge was getting the right care to the right people in the most effective way, because and recognizing that people trust us and depend upon us, and we have lots of longitudinal data on people. So our data is actually an asset in our closeness to the action, because we're in communities, including some of the small communities. Close to the action means that we can work and test things close to where the care rubber hits the road. So for the portfolio, then we look at there are 8 or 9 areas that we look at that are high level priorities to us. Number 1 is access to care. Number 2 is that the work that we do is sustainable. And that's because as a not-for-profit in a rural area with very challenged demographics, that concept of no margin, no mission is real. And so getting sustainable care, value-based care is in the portfolio, cost reduction, obviously, in the portfolio, managing social determinants of health, and being thoughtful about that, because so many of our patients have one or more significant social determinants of their health or barriers to care.
Creating a physician leaderboard is kind of an interesting concept that we came up with. The origination of the leaderboard was to do with how do we go about standardizing products and procedures. If we have to convince a physician to change their behavior, if we were to request them to change their usage of the products, we needed to come up with leaders in each one of those areas. So first we created a leaderboard for simply the cost for a particular product. The physician that had the lowest cost was the leader there. Then we went into the payers and looked at the same procedure and say, who is the leader in every dollar being billed and how much is being reimbursed. Then we went into the outcome of every procedure that a physician has done, and where is the leader there. And once we identified those things, then we brought all of that data into a single dimension, and we looked at who is a leader across the cost, the quality, and the reimbursement. Then we use that leader, and leader wasn't necessarily one person. There may be 3 leaders, 1, 2, and 3. Then use that sort of an insight to be able to change the physician behavior.
But we wanted a dashboard that we could look at, and that would integrate utilization, costs, revenue, and outcomes. And the last thing we wanted to do was implement a change in vendor or a change in product that was detrimental to our patients, no matter what the cost is. That was off the table.
What SupplyCopia was able to do for us is to take on the health system outcomes. They helped us create a composite score made up of mortality, morbidity, length of stay variation, and complications. And so you can now begin to picture what that dashboard looks like. Here is our number of cases that we did this year, number of cases we did last year. Here is the quality composite this year. Here's the quality composite last year. When we did initiated supply chain interventions and began to alter product usage, here's what happened to our costs.
And then they can see that with respect to all of the demographics of their patients, as well as their outcomes. So it actually takes all that information and then rolls it up into a single score to help them understand at a high level, how well they are doing in this space.
Reimbursement data is a very important metric in the analysis. Reimbursement data is stored in multiple financial systems within an organization, and it's necessary to bring that reimbursement data and associate that with every procedure in the organization to be able to understand who is our payer, what is our payer mix, how is that payer mix divided between the Medicare, the Medicaid, insurance, the self-insured, so on and so forth. That sort of a visibility is what's going to help in triangulating all of this sort of data. And then that helps you kind of paint a bigger picture to be able to say, okay, this is how much we are spending on a particular procedure. This is our demographics. This is how we are billing the insurance company. And this is how we are being reimbursed for every procedure. And then you look at, what is my percentage reimbursement for every procedure that, we have done within the organization. Why does it differ? And is there any indicators out there that we should be looking at? Or are there any outliers that we should be looking at? So layering in that payer data divided by, however the payer types are, and associating it with each procedure is very important, and that helps you in getting to the bigger picture of the organization. So once you kind of go through data cleaning, data classification, aggregation of multiple sources of the data, then you have to be able to create some actions out of it. It's not data analysis or data aggregation for the sake of doing so, because it's not necessary that just because you have a lot of data, that means you get great actions. No, it's almost like looking for a needle in a haystack. You want to be able to train your data sets. You want to be able to create these algorithms in such a way that from all of the data foundation that you have created, you want to be able to get, number one, the visibility into your operations. That's how your procedures are being done. Who is doing the procedures? What does that demographic looks like? And then be able to say, from the cost, the quality, the outcome, and the reimbursement, when I analyze all of this, what are my actionable results from there? So once you analyze all of this data, then that analysis will lead to actionable insights. And those insights are provided then to the stakeholders so that they can take appropriate action.
I think the biggest enlightenment to us was being able to have full transparency. Having full transparency is critical to increasing the value of a service line or a procedure.
That was our goal, to put it all in there so that we could have the cost and the quality and the outcome. It was very important for us to make sure that the changes that we were making were keeping us in a profitable state on those particular hips and knee cases. So having all of that information in one system so that the physician could actually see how they're doing from beginning to end was very important for us.
So achieving standardization is fairly complex, and it's also you have to convince multiple stakeholders. So the best way to do that would be to leverage the visibility and the insights that have been generated by the organization, looking at various leaderboards and other things, and then be able to say, for the patient demographics that we traditionally serve today, how do we go about standardizing the products and the procedures? Now, if we go through the standardization route, we have to constantly keep in mind the outcome of the procedures. It is not standardization because we want to reduce the cost. We want to be able to standardize the products and procedures, keeping in mind that the outcome of every procedure either remains the same or the outcome actually improves as a result of the standardization. So every organization will take their own route, but the end of the day, that standardization should help in not only improving the cost structure, but it should also improve in the quality of the outcomes that every organization has.
In the supply chain area, I think we've learned a couple of really important things. One is that the choice of the vendor makes a difference, and it's an important factor in the cost. No question about it. However, what we learned from this experiment is that factor alone cannot make the line sustainable, which is to say you can't take enough expense out of the implant to make this line profitable, and is unlikely to ever be that way. The idea that the way that you can influence the financial sustainability of this strictly on the implant, I think has given us some sort of a sobering view, is that we've got room there, but we can't solve the whole problem that way. Where we can solve some of the cost is by continuing to drive the clinical variation to minimal. There's I think a very significant opportunity in getting, in effect, the receipt of the procedure in real time in the surgeon's hand, the equivalent of the bill of materials being able to be put into the hands of the operating physician in real time.
Collaboration is the single biggest ingredient in this whole mix, because unless and until the clinicians, the executive leadership, the supply chain people, the procurement people, the value analysis people, if all of them don't come together and sing from a single place, then any kind of analysis, any kind of outcome that you generate is going to be not very effective. It's that data foundation, it's that visibility, it's that story that brings all of the leadership on the same common platform. And then once you are on the same common platform, then it's very easy to collaborate, because now you have evidence that is derived from the data.
The advice I would give is to be bold and initiate that engagement with the physicians and your organizational leaders. Expect that you're going to have different opinions, and that's perfectly okay. But, change will happen once everybody gets to the table and has those conversations, and everybody realizes that we all want the same thing. We want to provide excellent care. We want to provide, the newest, best technology. We want to provide everything that we can to deliver that care to our patients, but we want to do it in a way that we get rid of that unwanted cost.
Thank you very much for joining this session today. I greatly thank my colleagues from McLeod Health for joining and walking you all through their transformation journey. For more information, you could visit SupplyCopia.com, or also feel free to download the case study that's associated with this session.
Thank you, Ashok, Patrick, Michael, Carmen, and BJ. That was an invaluably informative presentation. On behalf of HPN, SupplyCopia, and McLeod Health, I would like to thank everybody who logged on to watch. Be sure to watch the other sessions in our forum, and please click the link at the top of your screen to return to the Event Hub.